Mr. Shola, good evening. Mr. Shola, good evening.
Thank you.
I will send the recordings to us individually so that I can see everybody. People will have the opportunity to listen to them again, and analyze them, and option on them. We'll talk about that modality again. Prisca, you're welcome, ma'am.
Thank you, Ma.
Like I said,
But I hope I'll be able to join.
and of course, we seem to strategize on how
Hello, can we do housekeeping now?
I'll try. How that strategy.
Please, can we do the housekeeping? Hello, if you can hear me, please, can we do the housekeeping?
Yeah, I can hear you. Good
Okay.
I can
evening.
hear you, ma'am. Good evening, ma'am.
Okay,
Good evening. Can you hear me?
Yes, I can hear you.
Please, I'm wondering if this Dr. Kotila is my Dr. Kotila from hematology.
Kotila is here. It's not Dr. Kotila from hematology.
Ah, okay. No wonder her voice was sounding different.
Yeah.
Good evening, ma'am. That's my
Okay.
sister-in-law, ma'am. My husband's
Okay.
elder
Okay.
sister. Yes, ma'am. Yes,
Okay,
ma'am.
that's nice. Well done.
Yes, ma'am.
Because when
Thank
you
you,
talk,
ma'am.
I'll be listening hard, and I say, it doesn't sound like her. Okay. My greetings to her.
I will, ma'am. I will, ma'am. I'm in pharmacy. She's the one in hematology, ma'am.
Okay.
Yes, ma'am. Thank you, ma'am.
Wonderful. Okay.
Yes.
Let me go and get water before I come back.
Hey,
Before
well,
Prisca.
did you send, Obi, did you check what I sent to you if you have any comment?
No, my dear, I just got out of a meeting.
Oh, okay, you will see yourself now. You better look at it before you go.
From you, go.
Yes, from here. You should be seeing it now. Everybody, are you seeing what I'm sharing?
I saw it now, Abby.
I'm asking if everybody can see it. So we have limited time because yes, the time is very small because we have many people, and we don't have any other space than now and next week. And next week, Dr. Fakone is joining. So we still have 3 people too.
I will go fast. I have some
very good.
slides, Sha.
Very
I'll try
good.
and go very fast.
Very good. So I've given everybody 35 minutes each. So God
I
will
have
help.
35 slides.
Slides for 1 minute. The Lord is your help.
Yeah, amen.
So that's everybody look at it. That's what it's like. We are starting 8 on the dot. We just welcome briefly. I don't know if moderator is in. If he can
This is
welcome
an
us.
important topic, Shao.
I know, but because you know of the thing, that's why we are squeezing. Those people who presented before, they had more than enough time because it's only one person that was doing.
Don't worry. It's okay.
Okay. Then this is the beautiful Dr. Eunice Ahmed that is taking us next. And I don't know whether I need to be, this is a powerful hobby. I think this is a powerful profile. Yes, this is the beautiful, very beautiful woman. I don't know her, Dr. Ahmed. She's so sweet. So this is what I have for her. This is what I have for you. I try to make it as compact as I can have. This is what I have for myself. I'm thinking that we should not introduce me to save time. Since I'm just introducing, giving overview tonight. Tomorrow we'll be doing details. And there was a problem that happened during the
introduction, Prisca.
You
don't need introduction again.
I beg, I said it.
No need.
So we can save time.
Let me go and get my water, beg.
Go and get your water.
I've been sitting down here since 6 o'clock.
But there's something I wanted to tell you before you go.
Okay.
We're supposed to have a breakout session tomorrow. And that breakout session tomorrow, we're supposed to be using, I assume that we're going to use this webinar. But this afternoon, we realized that the webinar cannot take us through breakout session. So we brainstormed. They said we have to pay additional $67 or $70 to round it off. I said, we already have more than enough budget for this, that we shouldn't incur any other. Since I'm the one handling that thing, I will look for how to handle it tomorrow so that we'll not do breakout.
It's okay now.
Okay,
If you need to break out, you need to pay. I don't think we have exhausted the budget. Have we? I don't think so.
You know, we have to run another one. So I'm of the opinion that we should just manage this one. When we finish, we now sit down, look at the budget, look at everything, and then we can now decide for the next batch if we are going to break out.
Okay.
Okay.
But I'm not attending tomorrow. Is this evening, right? Because I have quite a bit. Is
No,
this evening?
Your own this evening. See the agenda I'm showing you like this. Professor Biageli, your own is here 8:40 to 9:50. So
yes.
Dr. Eunice Ahmed is starting, and I will finish. Then whatever time is left for any question we can take on before we handle that.
So which genetic counseling overview are you doing again, Prisca? Haven't you done it?
You have not done any. No, you didn't know what happened the first day. I told you. We couldn't do it now because what we had was not enough. It took only 100 in and stopped. So we had to go and buy, get step down from this to another platform. And then 100 people were brought in to continue with this one. Then we had the pre-test, and then pre-evaluation and all those things. So the whole time just went away like that.
Okay, can I go and get my water?
Yeah, go and get water. Get anything you want to get. Bye-bye.
Can I eat my food?
Eat yourself, eat your food, do everything. And get ready for us. Okay, LOC, please, does anybody have any comments about, is Honorable Fawale in now? Because yes, I want to change, I'm going to change this welcome to you. I want to be sure you are in because. Yeah, so if you are in.
Prof.
Yes.
Ma, I have an observation and a concern.
Please go ahead.
Yes, I am driving presently, so I have made Honorable Fawale a co-host. It's our son. My laptop is on his laps. It's the one that is working for me. So I want Honorable Fawale to take over.
Can you make many people co-host, not just one person?
Yes, I made him and Dr. Kotila co-host. So
make myself also co-host. And if Mr. Aaron is in, make Mr. Aaron co-host or Dr. Ria.
Not in yet.
Okay, what of Dr. Riako is in? Yeah. Dr. Riako is in.
But she left.
No, she's in. I'm seeing her. Yeah. So that we will not, if anybody is not there, another person can take care of it.
Hello, ma.
Hello, I can hear you.
Yes, I have a concern.
Please go ahead.
I said that, yes, the WhatsApp platform that was created, I think we need to have dedicated persons that will be responding to queries that are being answered, because it's essential that we don't have a bad customer relation image, since this program is going to continue for 3-4 more cycles or more. So when people are asking questions and they are not getting answers immediately or within the shortest possible time, it tends to give a negative representation. So I don't know how we can do that. Yes, we know some people may be, making the same similar requests that others have made, but it's essential that we have persons who will be dedicated to checking on the questions being asked there and responding. For example, now, some people already have a sad tone about not getting the slides. It's only this slide we have. They are not even mindful that there is the audio recording that's been posted, and there's not been any response from us. So I think we need to look into that, ma'am. Thank you, ma'am.
Thank you, but you are there. So why didn't you answer the questions, Dr. Kotila? I didn't check the platform, so I didn't even know there's any question. But if you have checked the platform and you see any question, please just respond. Personally, for me, I think our program managers are the ones who are responsible for that. But when they are asking technical questions and they need us to be able to answer the questions, then there's a problem. I'm sorry.
Yes.
Sorry. I want to excuse myself from a meeting. Sorry, I'm running an international conference, and I'm there right now doing pre-planning. So I'm going to opt out of this. I apologize, please, Prof.
Dr. Kutila.
Yes, ma'am.
You know, those other platforms, I even had to draw Mr. Shola's attention to it. The other the platform, that's the first platform that you have like almost 1,000 people. Some of them are still, I don't know whether they want to deceive themselves or what. Like this morning, I noticed that somebody was telling somebody, help your sister with the link. So I had to pitch her. I said, did you take the pre-test? She said, no, sir. I didn't even bother to clarify whether it's a sir or man that is speaking, that is chatting with her. I said, then, boy, you have been told. I now have to, bring that, the address that Professor Prisca gave them, that for this cohort, if you don't take pre-test, you are not qualified to continue. Those people in that other platform, they are just, I don't know, why is it so difficult?
Wow.
An instruction has gone out, and you are still there. Even right now, they are still asking for link. Those people in other platform. But the people that are actually undergoing the training, they seem to understand what is happening. It's those other people that are just throwing questions, asking things that are not supposed. Like that one in the morning, I took it upon myself. I didn't want to respond to her in the general platform. That was why I just did a private chat to her. The first question I asked her, did you take the pre-test? She said, no, sir. He said, no, sir. I said, but this thing has been, I now went back to the general platform, brought out the announcement that Professor Prisca gave them, that if you did not take pre-test, you wait for the next cohort. I still send it to her. I said, my advice for you is stop looking for link now. Just hold on. Since you registered, I now asked her, did you register? I said, yes. I said, okay, since you registered, you wait for this batch to end. You will probably be in the next batch. She now said, thank you. So, human beings, I just don't understand. But if it's the ones that are undertaking the training, they don't post questions anyhow. It's those ones that are not really in the training that you see passing comments here and there. Because I check the platform from time to time, though I don't respond on the platform. Like this morning, when I noticed this one, that somebody is looking for somebody, help your sister with the link. That was the language she used. Help your sister with the link. I quickly informed Mr. Shola. I'm sure that was why though I joined the 3 o'clock meeting late, I'm sure that was why the decision was taken to send the link late and not earlier than that, so that they don't go about sharing it.
Yes, Mr. Shola call our attention to that fact.
In fact, the moment they had talked about new. Oh, okay. Sorry, ma'am.
Okay, thank you. We have 9 minutes more.
I'm true.
Can you?
Yes.
Honorable
Yes, ma'am. I was saying that
tonight. Okay.
Oh, okay.
We have just 9 minutes more. We'll debrief after for other things.
Nigerians are lawless people. People should just be very strict. Is it because it's a free test?
No. You know what happened, Professor Obiageli and Professor Nodu? You know what happened? We left that big 1,000 people platform on. So those people who are not able to join this particular session are asking question. And I've already told them that they should wait. They are asking, when is the next batch? When are we going to start? When are we? I didn't answer them because
shut the platform down now.
If we shut, it will be difficult to get all of that. I just want us to finish this one next week, and then we'll have taken a decision of when. I want us to look at the budget. I want us to finish while they are doing hands-on. That 2 weeks, we can look at everything together, and we can now say, okay, we are doing this one at this time. We had a meeting yesterday. Professor Ojegbede was there. I said, sir, I agree we should run, but let's finish this one. Let's look at the totality of what we have done, and then now, plan for this next batch that we are talking about, because it's very easy to say, let's go on. Otherwise, we start looking for them again. So once they're already in the cohort, all this have done, they won't do again. So that platform is still going to be very useful. And then we will not advertise to anybody and anywhere, so that we are just taking them. But me, I don't have time for them. I just want to face this one and finish first. Once we finish, we'll come back and fall back on the information we've given them. So I think we should not close it. We should leave it. We should not mind them. Let's just finish this one.
I have three new nurses to put in the program. The next batch.
One.
Yeah.
The next batch. Okay. No problem. If there's any, I'm sure that not all of them will be patient enough to wait for us. So some people will drop out. Because this particular webinar cannot take more than 500. If you want to take more than 500, we have to expand and make sure we have the type that can take breakout session, because that breakout session is important. But I want to make sure we sort out budget, sort out everything before we take any additional expenses. So far, so good. I've just spent only $100 that we used to buy this webinar that we are using. That's all. So I want us to finish, come sit down and sort out all the budget. Maybe in the week, next week, before we come for the last week, we should take that decision. Okay, Honorable Fawole, you have
Prof, please, we need to round off these housekeeping. Attendees are already in the room.
Oh, they're already joining us. Okay. More 49 people already. Okay. It's all right. So 8 o'clock on the dot, Honorable Fawole, you come in and welcome us. I'll help you with the introduction to make life easier for us. And then you can go through this. This is what we want to do. Hemoglobin electrophoresis and testing. Mr. Aaron, is Dr. Eunice Acheamp in? Please, can we get the
Aaron is not here, but Dr. Eunice is here. She has joined the panelist now.
Okay, good evening, Dr. Eunice. Please, your slides are with you, right? And you are ready because you are the first person to start. Please, can you just say respond so that I'm sure you can hear us and you are here with us. We have 5 minutes.
No, I'm not sure Eunice is here.
Somebody said she's here.
So I'll just look in that.
I saw her and I made her, maybe she just dropped off again.
Okay.
Please, can somebody help us to get her so that we are sure? If not,
Mr. Shola, Mr. Aaron is here, but he's an attendee. If you want him to come up, Mr. Aaron is around, but he's an attendee.
Please, can you?
I can drop off for him to be a panelist.
No, you don't have to drop off now. Kilode?
Okay. But Mr. Aaron is around. Mr. Aaron is around.
Okay.
You don't need to drop off. The last time
upgrading. We have 4 minutes more.
Maybe just...
Honorable Fawole, you welcome us. Then tell us all of this here in 2 minutes. We are going to have hemoglobin electrophoresis and testing, newborns by Dr. Eunice Acheamp, newborn screening, Professor Obiageli.
One investment.
Who said something now? We have 4 minutes. Somebody is talking. Who is the person? So that immediately this is over, I'll just go ahead. I'll put all the slides here. The next person to be introduced is Dr. Mrs. Followed by Obi, then myself. I think you should leave my own to save time. I have a presentation tomorrow, so we can be doing my own introduction.
No, Prof, go on.
Okay, thank you. So I think you can just introduce these 2 people, and then I've been on the platform, they've been seeing me since. I'll just take the presentation straight, and then tomorrow, when we have a bigger presentation, then we can be looking at introduction with the people who are going to make presentation tomorrow. Okay. I think that's about all. And then you invite Dr. Eunice Acheamp to take her presentation. After that, Professor Obiageli. After that, should we take questions at the end of everything? Because I'm afraid the time.
I want to ask, what about the biography of Dr. Eunice?
You are not here, Honorable. I said this agenda, just talk about this. If you want to introduce, they are all here. This is Dr. Eunice Agiman Ahmed. This is Professor Obiageli Nodu. This is Prisca. But I'm saying that let's leave Prisca alone because I have presentation tomorrow again and introduce Obi and Dr. Eunice. So
Okay, so it's going to be on the screen, so I'm able to
no,
read.
don't worry. I will take it to make it fast because I wrote it and to be faster.
So Dr. Eunice is actually among the participants. So I think she should be
up to
upgraded again.
And who is monitoring that place? This Honorable Fawale that you gave this doctor, who else is co-host? Can you be on the lookout for presenters? There's no reason why the speakers.
Dr. Eunice is around now. She's among the
panelists.
Participants. Yeah, no participants for now.
What I'm saying, we need somebody monitoring that space.
Be upgraded.
Mr. Aaron, can you do that also? Mr. Shola, can you make Mr. Aaron a co-host too? So that if anybody drops off, you can bring the person back as a panelist. If the moderator drops off, he needs to put his eyes on Q&A and be monitoring the questions. You didn't answer my question. Should we take Q&A at the end of everything? Because I'm afraid the time we have is not much.
That's what we have on the agenda. I think it's better.
Very good. So we take question and answer at the end.
I just upgrade Dr. Eunice to panelist now so that she's able to talk when the time comes.
But you know, because you will put your eyes on the Q&A, because there are going to be many Q&A, since there are going to be 3 presentations, and you have to be picking all those questions in one folder or one word, so that you will not miss any question. They will not disappear. You'll be copying and be pasting whatever you want to ask them. And if there are repeated questions, you remove them. So you are busy on that Q&A after this introduction, and you have gone off. Is that okay?
They should not disable all these Q&A. They've started.
No, we have put it at the end. We have put it at the end. Only one Q&A that is there after all the presentations. There's no time self in this one. Okay, it is 8 o'clock. Honorable Fawale, take it from there.
Mr. Aaron is a panelist now.
Mr. Aaron should not be a panelist. Bring him up. Okay, he's a panelist. Thank you. Honorable Fawale, over to you.
He's a panelist. I've upgraded.
Thank you. Okay, it's okay. We are starting. It's 8 o'clock. Thank you all. Over to you, Honorable Fawale, please.
Oh, thank you. Good evening, everyone. We welcome you to today's the week 3, day 1 of the training on genetics counseling in sickle cell disease. I want to say akwaaba to our participants from Ghana and all our participants from Nigeria. I want to say welcome to you. We are about today's today's session. You're welcome. I could see that many of us came very early already, and that's very impressive. And today we'll be discussing on major 2 very important topics, which put us around 1, the hemoglobin electrophoresis and testing, which would be taken by Dr. Eunice Ahmed, and also newborn screening by Professor Obiageli Nodu. I'll be handing over to Professor Prisca to take over from me, and also Professor Prisca Adejumo will be taking the overview of genetics counseling. But right now, since we're about to start, I'll be handing over to Professor Prisca to take the biography of our first speaker, who is also already in the room with us, Dr. Eunice Ahmed. Thank you, and over to you, Prof.
Thank you very much for that kind welcome from you, Honorable Fawale. So we are moving on very quickly to have our speakers introduced. And tonight we have very beautiful speakers. The first on the list is Dr. Mrs. Eunice Ajiman Ahmed. And it's my honor to introduce her to us tonight. Dr. Mrs. Eunice Ajiman Ahmed is a hematologist and the head of the clinical hematology unit at the Komfo Anoke Teaching Hospital in Kumasi, Ghana. She obtained her medical degree at the Kwame Nkrumah University of Science and Technology, NUST in Kumasi in 2012. Following this, she pursued specialized training as a hematologist and transfusion medicine specialist at the Ghana College of Physicians and Surgeons in Accra, completing her training in 2018. Currently, she's pursuing a PhD in global health at the Liverpool School of Tropical Medicine, UK, focusing her research on sickle cell disease. Dr. Ahmed is deeply committed to enhancing sickle cell disease care in Ghana, and actively participating in various advocacy, education, training, and research initiatives. In addition to her clinical and research commitments, Dr. Ahmed lectures on a part-time basis at the School of Medical Sciences, NUST, and the Faculty of Hematology at the Ghana College of Nurses and Midwives. Permit me to introduce our next speaker after this, because there's not going to be time in between, so that immediately after her comes up our very own Professor Obiageli Nnodu. Professor Nnodu is Professor of Hematology and Blood Transfusion, Director, National Center of Excellence for Sickle Cell Disease Research and Training at the University of Abuja, Chester. She is the National Coordinator, ASH Consortium for Newborn Screening in Africa, CONSA, Principal Investigator, SPACO Nigeria, Abuja Coordinator for Sickle Gen Africa, co-PI for the UK NIHR Patient-Centered Management of Sickle Cell Disease in Sub-Saharan Africa, MPI for Managing Sickle Cell Disease through increased adoption of hydroxyurea in Nigeria Accelerate, and contact PI for the NIH FIG D43 Spark Train Grant. She serves as an expert on technical committees on non-communicable diseases with the Nigerian government and as consultant for international agencies, including the WHO Afro. She's a fellow of the Nigerian Academy of Medicine, chairperson of the Sickle Cell Support Society of Nigeria, special advisor on sickle cell disease to the Coordinating Minister of Health and Social Services, as well as chair of the recently concluded 5th Global Congress on Sickle Cell Disease. We have very big fish in the house tonight. I'm going to invite Dr. Mrs. Eunice Ajiman-Ahmed to please take it away from me and then begin our presentation for the next 35 minutes. Thank you very much, Dr. Ahmed, and you are welcome.
Thank you very much. And I'm honored to be called upon to facilitate this session of the genetic counseling course. I think so my name is Dr. Ahmed, and then I'll go ahead and share my screen if you permit me, and then
yes,
start.
Go ahead. Thank you.
Are you able to see my screen?
But is this slideshow?
No, I'm going on to that.
Yes, thank you.
All right. Okay, so my talk today will be on decoding hemoglobin electrophoresis and testing for sickle cell disease. Okay, so just a brief introduction. So we know what sickle cell disease is. It's a genetic blood disorder affecting hemoglobin. And we know that the inheritance is autosomal recessive. So you need double abnormal genes to be able to manifest the disease. And it's a problem for us in sub-Saharan Africa. Okay, so why do we need to test for sickle cell disease in the first place? So there are for two major reasons, for screening and for diagnosis. So for screening, we talk about the newborn screening, which Prof. Nnodu will be talking more about. So screening is mainly testing healthy newborns or newborns who don't necessarily show symptoms of the disease to be able to detect whether they have the disease or not. And then in screening as well, you can use that in couples who are planning to get married, what we popularly call as the premarital screening, or in couples who are planning to conceive. Also, in individuals who are diagnosed to have sickle cell disease, you may use testing to check the genotypes of their relatives to see whether they also have the presence of disease, whether or not they show symptoms. And then the second arm is for diagnosis. So in the clinical setting, when you have an individual who presents with anemia, jaundice, maybe recurrent bone pain, features which may be suggestive of sickle cell disease, you may want to go ahead to test to confirm whether they do have sickle cell disease or not. And also in patients or in people who end up with a positive sickling test. So the sickling test is a very rapid test that is used to ascertain whether an individual has the presence of an S. So if it turns out to be positive, it could mean it's the carrier states, or what we call the sickle cell trait or disease. So once you have a positive sickling test, you may have to go ahead and test with a more confirmatory test, like what we'll be talking about shortly. Okay, so there are various types of tests that are used to determine one's or to diagnose sickle cell disease. And I've grouped them under the hemoglobin test, the rapid test, and then the DNA-based test. The hemoglobin test are those that help us differentiate the different types of hemoglobin present in an individual. For instance, hemoglobin electrophoresis, which will be the topic for our discussion today. And the rapid test, I already mentioned the sickling slide test, which is a rapid test to determine whether an individual has an S present. Okay. There are also the newer point of care tests, like the hemotype SC test, which can also help us determine one's sickle cell status in a very quick and rapid manner. The DNA-based tests are tests that would help us determine the genetic defects. So this test it at the molecular level to determine one's sickle cell status. Okay, so now talking about the hemoglobin test, there are various types. There's a hemoglobin electrophoresis, there's isoelectric focusing. Isoelectric focusing tends to be the one that is used in the newborn, typically used in a newborn screening, but of course, it's a more expensive and it's a bit more complex. You need someone who is more skilled to run it. So eventually, it may not necessarily be cost effective for every context, okay? And there's a capillary electrophoresis and then the high performance liquid chromatography. Okay, so the last three, besides what the HB electrophoresis do, it can typically tell you the quantities of hemoglobin that an individual has. So besides identifying the different types they have, it can also provide additional information. That's the exact quantities of the different variants of hemoglobin an individual has. I would say they're a bit more costly compared to the HB electrophoresis, but they're also very, very useful, especially if the hemoglobin electrophoresis has challenges in some situations. Okay. All right. So we'll talk more about the hemoglobin electrophoresis. Okay. But before we go into that, I just want us to remind ourselves of what hemoglobin is. So we know that hemoglobin, it's a protein that is present in our red blood cells. So our circulating red blood cells have hemoglobin, and that is the protein that helps us carry oxygen to various parts of the body. And the hemoglobin is made up of 4 polypeptide chains. So it's what we call a tetramer. So in someone with hemoglobin A, they've got 2 alpha and 2 beta globin genes. Okay, so in someone who has hemoglobin A2, they have 2 alpha and 2 delta chains. Or if the person has hemoglobin F, they have 2 alpha, 2 gamma chains. And at the center of each polypeptide chain or the globin chain, you have the heme sitting in the center. So heme is the part that actually oxygen will attach to for it to be transported around the body. Okay, so there are various types of hemoglobin. The one we call hemoglobin A is what a normal adult tends to have. Okay, and there are variant ones like hemoglobin S. And we know that in hemoglobin S, it occurs because there has been a mutation at the gene level, and this leads to substitution of glutamic acid for valine on the beta globin gene. Okay, so that results from a mutation. Hemoglobin SC, also occurs as a result of a mutation similar to S. And then hemoglobin F is the hemoglobin that is predominant in newborns. Okay, there are many, many other types of hemoglobins, but we'll only focus on the common ones. All right, so this is just to give us an idea of what to find in an adult who does not have sickle cell disease. Okay, So they predominantly have hemoglobin A. And this is about 95 to about 98%. And there's always this small amount of hemoglobin A2, typically between 2 to 3%. And then there's hemoglobin F, but usually that should be about less than 1%. So you don't expect to find hemoglobin S or C or E or any other abnormal hemoglobin in a normal adult. And in a child, this varies based on the age of the child. So in a newborn, that's when you find the most abundant form of hemoglobin F, okay? So they can have as high as 80% in a newborn period. And as the baby grows between 3 to 6 months, they begin to switch from hemoglobin F to the adult form of hemoglobin, that's hemoglobin A. So more than 6 months old, you don't expect to see significant amounts of hemoglobin F. They'll begin to have a picture like what a normal adult will have. Okay, so now moving down to hemoglobin electrophoresis. It's a laboratory method that is used to separate the different types of hemoglobin. So hemoglobin A and its variants, so SC, ED, and any type of hemoglobin that one has. Okay, and separating hemoglobins using this method is based on the charge that's on hemoglobin. So hemoglobin electrophoresis is done in an alkaline medium. And in the alkaline medium, which is around the pH of about 8.4, hemoglobin would have an overall negative charge. So when it's subject to an electrical field, it'll begin to move from the negative points or the cathode towards the anode, which is the positive end, because negatives will attract. Okay, so it's based on this principle for separating the hemoglobins in an individual. It's able to detect the AS, that's a sickle cell trait form. It's able to detect an SS and some other variants. So there are two main types of electrophoresis. There's I talked about the alkaline electrophoresis, that's the cellulose acetate electrophoresis, and there's the citrate agar electrophoresis that is done at an acid pH, unlike the cellulose acetate, okay? And basically, they all separate hemoglobins. The cellulose acetate is the most common type that is used. It's also relatively cheap, and it's straightforward, let me put it that way, okay? It does have its own limitations, and sometimes the citrate agar comes in to complement the cellulose acetate in areas where you cannot separate certain hemoglobins. Some hemoglobins migrate together. So sometimes when you need to distinguish the differences between those hemoglobins that are remaining in a particular position, the citrate agar will come in handy. I'll go through the process so you begin to understand what I mean by separation and bands and all that. Okay. All right. So now we start from sample. So what sample do you take if you are going to run hemoglobin electrophoresis? Usually you take an anticoagulated blood. So the blood is put in an EDTA tube commonly. You can use most other anticoagulant tubes like a heparin, but commonly the EDTA tube is what is used for hemoglobin electrophoresis. And when the sample gets to the lab, and the laboratory scientist or the laboratory technician will run the electrophoresis. And basically, as I said, it runs using an electrical field on using electricity. Okay, so there's a power supply, there's an electrophoresis tank, and there's a buffer. The buffer, as I mentioned, is at alkaline pH for hemoglobin electrophoresis using cellulose acetate. Okay, so these are the sample wells where the sample will be applied, and then this is the negatively charged end of the electrode, and this is a positively charged end. So ideally, the proteins, the hemoglobin, sorry, are supposed to migrate because we said they have a negative charge. They will migrate towards the positive end of the electrode. And the rate at which they migrate will depend on the strength of their negative charge. So the stronger your negative charge, you move further closer to the anode, which is a positive charged end. Okay, and this is how basically electrophoresis happens. Okay, so on the right-hand side of the image, so as you see the point of application, and then they migrate. Okay, So looking at the common hemoglobins, hemoglobin A is the one that migrates the farthest towards the anode. So you see, it'll form a band here. So you apply your sample here. And if the sample contains hemoglobin A, it migrates towards the anode to the farthest, and it stops at this point. And it's followed by hemoglobin F. So it's a band that forms after or behind the hemoglobin A. And then the other types like S, D, G, L, they migrate together. So any of these hemoglobins will migrate and form a band in this area. And then hemoglobin C, and then the other variants, hemoglobin A to E, O, Arab, C, Harlem, they also form in this region, okay? So this is just to shed light on how the interpretation is done. So basically, after the electrophoresis is run, and the bands would form, and then you stain them so that you can be able to read them. Okay, so in every electrophoresis test that is done, they run a control. The control has in it all the relevant hemoglobins or all the common hemoglobins to help us guide us as to where the bands will form. So in this, on this slide, the control band or the control line is what my cursor is pointing to. Okay, so in your control, hemoglobin A forms here, F forms here, SDG forms here, CEO forms here. This is the point of application. Okay, so you compare each patient sample to this control to be able to interpret it. So on the top line, this is what we expect for a normal adult. Okay, so we expect that a normal adult will have predominantly hemoglobin A. So you can tell that from the point of application, there's migration and the bands have formed very strongly in the position where hemoglobin A is. So this person has predominantly hemoglobin A. And you can see a faint band here, which most likely belongs to A2, because we said in an adult, they have a small percentage of hemoglobin A2. Now let's see what happens to the newborn. In the newborn, we said they would have predominantly hemoglobin F. So you can see there's a very strong, deeply staining band here, which corresponds to hemoglobin F region. Okay, they do have some A as well. Okay, because the F, it's about maybe 65 to about 80%, and the rest will be the normal adult hemoglobin, which is hemoglobin A. And in an individual with sickle cell disease, particularly the SS, or in this case, the SS phenotype, you have bands forming in the S region. You can tell that everything they have in here is within the S region. And for the sickle cell trait, we know they have AC. So you can tell that there's the A region as well as a band forming in the S region. So that's how you interpret it. And SC will form a band in S region as well as a C region. Okay. So I mentioned there's another form, which is a citrate agar electrophoresis. It works on a similar principle. The difference is that it's conducted at an acid pH and it's able to differentiate some of the bands that the cellulose acetate is unable to differentiate. Okay, so for instance, for the cellulose acetates, S, D, and G migrate together. But in this one, S and D migrate very differently. So if there's some conflicts with your cellulose acetate, your citrate agar can come in to resolve those conflicts. Okay, so now let's have an example. I don't know whether we can take questions from participants or because I have a test strip that I would want people to make suggestions of. I don't know whether you can type in the chat box. Either ways, I think it works. So this is an electrophoretic strip. And then this is the control. So line 1 is the control. So in control, you see an A, an F, an S, and a C. Okay, so these are patient samples, 2, 3, 4, 5, 6, 7, and 8. Okay, so which of these patients between 2 and 8 have sickle cell disease? Can we have some suggestions?
I do not think participants can talk.
Oh, they cannot talk. Okay. All right. So
They are
so
typing. They are typing. They are typing.
You can just check the chat box for responses.
okay.
Okay, yeah.
So
So some of them are typing in the chat box.
okay. So I can see patient number 4. Someone is suggesting patient number 4. So let's check. So patient number 4 has a band in the S region, and that corresponds to hemoglobin SS disease, correct? Any other? 7. Okay, so looking at patient 7, they have a band forming in the corresponding to the S region and the C region. So that's an SC. Okay, good. Now, can we also check for patients with sickle cell trait for the question 2? Which of these patients 2 to 8, which of them have the sickle cell trait? Okay, so I see patient 6. So patient 6 has a band in the A region as well as a band in the S region. So yes, you are right. So I think my job is done. So you understand the principle of HB electrophoresis. Okay. So what abnormality? I think we've done the third one as well. Someone has already mentioned that the 7th patient has hemoglobin SC. Okay. So basically that's how the reading is done. Okay. So after the test is conducted, now it's up to the clinician to interpret the results. Okay. And the results interpretation has to be done in the clinical context. So you don't read results in isolation. That must be linked back to the patient in question. So when I say the clinical context, basically what I'm saying is that the patient should have a strong or a suggestive history. So a patient maybe has anemia or has jaundice, recurrent pain episodes, okay, or has any sickle cell disease complication, okay, or the patient has a strong family history of sickle cell disease. So maybe has siblings who also have the disease, or they have parents who have carried the abnormal gene and possibly can pass on to the patient or the individual, okay? And also you need your full blood counts, or your complete blood count, and where you take into account the hemoglobin level. Okay? We know people with sickle cell disease tend to have a lower than normal hemoglobin level. You also have to look at the mean corpuscular volume, that's the MCV, which tells us about the red blood cell size. So if you have a high MCV, that means that the red blood cells are big. If you have a low MCV, means you have small red blood cells. And also the MCH, which is the mean cell hemoglobin, that tells us about the concentration of hemoglobin within a red blood cell. So if your MCH is high, it means that you have a lot of, or high concentration of hemoglobin within the red cell average. And if it's low, it means the concentration of hemoglobin is low. Okay. And iron studies is also relevant here because sometimes iron deficiency can confuse a picture of particularly the thalassemias, okay? And then a red cell morphology, so that's your blood film or your peripheral blood smear. So you have to interpret all of these in that context to be able to decide whether your patient's results tallies or ties in well with the patient's lab results, okay? All right. So I think we've already discussed these. So anybody with double A, hemoglobin AA, is said to have normal or it's non-sickle cell. And AS has a sickle cell trait and they do not have the disease. When you have double S, you have sickle cell anemia or sickle cell disease, specifically sickle cell anemia. When you have SC, you have sickle cell disease, which comes about because a compound heterozygous, okay? And then we should not forget the AC traits, okay? AC traits, they don't have sickle cell disease, they don't have any clinically relevant hemoglobin disorder, but they have the potential to pass on the C to an offspring. So let's take note of that. Okay, so usually after your electrophoresis and you have your results, The recommendation is that you have to confirm with another hemoglobin test, okay? Sometimes we don't because maybe resources may be limited, but the ideal thing is you don't have a definitive result from an HB electrophoresis only. You should have a confirmation using another test besides your HB electrophoresis, like an HPLC or an isoelectric focusing, okay? Because we talked about the limitations that the HB electrophoresis is prone to. So you want to make sure that you have the right results in any context. All right, so now let's look at some advantages of the HB electrophoresis. It's relatively accurate in detection of the common abnormal hemoglobins like the CS, okay, which is a common type of sickle cell disease you find in our part of the world. Okay, and then it's also widely available. It's cost effective, and then we can use it to guide clinical management in most situations. And it can be used for genetic counseling and also useful in family studies. So it has a number of advantages, okay? And then let's also look at its downsides. So the pitfalls of HB electrophoresis. In a newborn or in early infancy, you cannot use that to determine the sickle cell status of a newborn because we mentioned that newborns have high hemoglobin F, and this can sometimes mask abnormal hemoglobins. So for instance, if the patient has S or a C, because of the predominance of the hemoglobin F, it can give you a false result. Okay, so you don't use the HB electrophoresis in early infancy, okay? So anytime beyond 6 months, when the child has switched from the fetal hemoglobin to adult hemoglobin, then that you can use that test more reliably, okay? And also in patients who have had a blood transfusion, this may alter the result of HB electrophoresis because in this case, the patients would have donor red blood cells and that therefore donor hemoglobin present in their own, and this will mix in their blood, and it may give, it may not give the true picture of what the patient has in terms of hemoglobin pattern. Okay, and as I've already mentioned, it cannot differentiate certain variant hemoglobins, okay? And then also when one has alpha thalassemia, you cannot use HB electrophoresis to determine that. And when it comes to beta thalassemia, it does not tell you completely that the patient has beta thalassemia, but it may give you some pointers. So in patients with beta thalassemia, they have raised hemoglobin A2. I did mention A2 early on in one of my slides. So people with beta thalassemia have raised A2. And if we interpret it in the context of the complete blood count, typically people with beta thalassemia would have low MCV, which is low red cell size, and low hemoglobin concentration, okay? You might be able to infer that one could possibly have thalassemia, especially when it's co-inherited with the hemoglobin S. So that's the hemoglobin S beta thalassemia form of sickle cell disease, okay? So to be able to accurately determine alpha and beta thalassemia, you need to do DNA analysis, okay? So what's the role of hemoglobin testing in genetic counseling? So it will help determine the carrier status. So people who are asymptomatic but carry the sickle cell gene and potentially can pass on to their offspring. It helps to guide family planning decisions. So if a couple are trying to start a family and then they know their sickling or their sickle cell status or their genotype, or more appropriately phenotype, they can make more informed choices, okay? And also it will identify at-risk couples early enough so that they either decide to go in together in marriage or they may go their separate ways for the interest of future children they would have one day, okay? And basically it helps reduce the burden of sickle cell through prevention. So the best way of dealing with the sickle cell problem is to prevent. So once you know your genotype, you can be well informed, or you can be well educated so that you can take very good decisions about how you want to start a family and then all the risks that are associated with it. Okay, so in conclusion, HB electrophoresis is critical in sickle cell screening and diagnosis, and its use is maximized when combined with the clinical context, as I said. Okay, and in genetic counseling, it can help us counsel couples, counsel people, families, so that they make well-informed decisions concerning future children. All right, thank you very much. And over.
Honorable Fawale.
Yeah.
Okay,
thank you so much for the presentation, ma. We really appreciate it. There's been quite a number of comments in the what do you call it, question and answer, session. I would read a question from Mr. Richard.
No, sorry, Mr. Fawale. Honorable Fawale, we are taking all the presentations first, and questions will come at the end. So just note the questions.
Okay, I'm noting the questions already.
Thank you. So you can stop sharing, and Professor Nodo will share her screen. Thank you.
Okay. Good evening, everyone. I'm delighted. Thank you very much to the organizers for inviting me to make this presentation. And I'll be speaking on newborn screening for sickle cell disease. So the background has been nicely set by Dr. Eunice, whom I share a first name with. From the Kwame Nkrumah University. She's an adult hematologist. So I'll be speaking on newborn screening for sickle cell disease. And this is a very important subject. So I'll be using the following background: what it is, why it's important, the protocols that are available, the delivery systems, how feasible and acceptable newborn screening is, what are the challenges to the implementation of these programs in our subcontinent, what are the possible alternatives, and how we can go beyond pilot projects to national newborn screening programs. And then I will be talking about the role of genetic counseling in newborn screening. I'm sure that some of you who have been on this course for the past 3 weeks have had enough about the epidemiology of sickle cell disease. We just know that this is a problem that is growing in our continent because of the high birth rate within the continent. And we know the morbidity and mortality that this poses to babies that are born in the continent, such that majority of them will die before their 5th birthday, and more will even die if they are poorly managed and they are not able to attain adulthood. And so for people who want to deal with other disease conditions, if within Africa, if they do not pay attention to sickle cell disease, the countries will not be able to attain their SDG goals for the countries. And it's also important for us to know that it's not just the under 5 or the infants, but that sickle cell disease is a leading cause of mortality in youths and in adults, below 50 years of age. So this slide is very important, and it tells us about the basic interventions for us to control sickle cell disease. One is raising the public awareness, newborn screening, which is our topic for today, And there's screening for sickle cell disease at primary healthcare centers, not just when they come into hospital. Having a registry of patients with sickle cell disease so that we can prospectively follow them up and carry out surveillance for complications, and then we can intervene. Then establishing prophylaxis for infection, pneumococcal vaccines, oral penicillin, the use of insecticide-treated bed nets, and anti-malarial treatment for those who have sickle cell disease early enough. Having a health maintenance and at primary healthcare center. You notice I keep talking about primary healthcare centers because this is the way that we can achieve universal healthcare coverage for our population, and then making sure that they have access to comprehensive care. And of course, the topic, the reason we're having these webinars is because genetic counseling is very important for those who have sickle cell disease, as well as those who are carriers. And genetic counseling should actually target this if we can do anything about reducing the prevalence of sickle cell disease. Nutrition is important. Education of patients and caregivers very important, to know what to do in acute conditions before coming to the hospital. And something as simple as optimal hydration, is some of the things that we teach them. But newborn screening itself is a 6-part system which includes education, screening, short-term follow-up, diagnosis, management, and evaluation of the program. And normally, when we talk about newborn screening, it's the whole host of conditions that are tested. But here in sub-Saharan Africa, because it's a very high prevalence, we are majoring on sickle cell disease, thalassemia, and other abnormal hemoglobin variants. I know that some countries are also talking about including congenital hyperthyroidism and glucose 6-phosphate dehydrogenase. So, what is the evidence, that newborn screening works? Most of them have come from the US, and one study in sub-Saharan Africa. We have these studies in the 70s and 80s were able to tell us that babies who have been screened have early have been able to survive when they're identified at birth. More have survived than when they're identified in early childhood. And babies who received pneumococcal vaccines have significantly lower invasive pneumococcal disease. And then babies who also have received oral penicillin have been able to do better, and they are less likely to have a fatal bacterial infection. And those who have received hydroxyurea therapy and those who have received surveillance for risk of stroke and blood transfusion when they are at high risk, these babies have been able to do better. And that is the justification for urgent universal newborn screening systems and increased access to sickle cell disease treatment. So it's not enough, to screen. If we get them at birth, then we have to give, from birth to 5 years of age. These are the interventions that we want to make sure that they have: daily penicillin, anti-malarials, full exposure to vaccines under national immunization programs, and add-on vaccines of PCV, 23, and meningococcal vaccines and boosters, and hydroxyurea, nutrition, just like I said. But education of the caregiver is very important, and the resources are there available within our healthcare systems to do this. Dr. Eunice has talked about, diagnosis of sickle cell disease, so we didn't bother too much about it. But one thing I want to say is that these cellulose acetate electrophoresis is not the method of choice for newborn screening because of the high level of fetal hemoglobin that makes it less likely to detect the low levels of hemoglobin S in that period of life. So we want to use other modalities like isoelectric focusing, high performance liquid chromatography in the public health space. And then in research, we can use molecular studies. In recent times, because of the challenges of implementing newborn screening in African countries using standard test methods such as HPLC, which is very expensive, isoelectric focusing, which you need a lot of skill for, supply chain logistics. People have come up with very sensitive, low cost point of care tests. And there are the front runners, the sickle scan and hemotype SC. And recently, we have the Gazelle, which also quantifies the level of hemoglobin, separates it into those fractions that Dr. Eunice was talking about, so that you can know exactly how much of A, how much of S, how much of F, C that is there, and A2. So these are very important progress that we are seeing. But the good thing about the point of care test is that it doesn't require electricity, and you can get it really at the point of care. So when can the diagnosis be made? We are looking at prenatal diagnosis, through molecular studies. We are looking at the newborn period, and we are looking at post newborn in infancy and teenage. Of course, throughout life, diagnosis for sickle cell disease can be made, and the method will depend on how much infrastructure is available. But one thing about the point of care test is it can be done even in remote areas, and you don't need so much training to be able to do that as IEF and HPLC. So we need to pay attention. So I sent this Lancet hematology article defining global strategies to improve outcomes in sickle cell disease. That was the Lancet Commission that was came out a few years ago. So it's very important reading, and I want anyone here to look at the section on screening and prevention, and it's very pertinent to our discussion this evening. So what are the approaches to screening? So we look at the available technology, we look at the evidence of benefit, and we look at the disadvantage and the challenge that it has. So for mostly, we are using heel stick. Rarely do people use cord blood. I know in some countries they go that route, but for the most part, it's a heel stick and is very accessible within the public health space. So we're having a isoelectric focusing, HPLC, capillary electrophoresis, mass spectrometry, and point of care tests. So you can see that in some other tables I'll be sharing that isoelectric focusing is widely implemented. There's extensive experience with it. It's beneficial. The benefit has been abundantly demonstrated, but it's labor intensive and extensive expertise is needed to be able to do it accurately, as well as you need a good quality assurance program. HPLC and capillary electrophoresis are used in newborn screening programs in the UK and France. It has a high cost of equipment and reagents. Mass spectrometry is being touted that it can be used where you have labs that do a heavy bacteria work, but it's very high cost, and it has extremely high throughput if anybody is able to get one in there. But point of care tests have been successfully implemented in newborn screening programs with evidence of benefits in Nigeria, in Haiti, in Ivory Coast, Ghana, Martinique, and the Gambia. And it was Dr. Adegoke that actually carried it out. But it's not enough to have newborn screening. Every child with a positive result, and I borrowed the bottom part of this from our Heroes program, should be followed up for confirmatory testing and appropriate intervention. So this follow-up is very important. The mothers should be informed about the test results, soon afterwards, and then results, should be given to them so that counseling can be done by people who are trained for it, and the test results should be recorded in the Road to Health chart. And then, of course, confirmatory testing should be done, and the mothers of positive babies who fail to collect the results can be tracked by the nurses in the immunization clinic, and then the results should be consistent. The results should be consistent. The newborns with results consistent with possible sickle cell disease should be appropriately referred, even when they don't want to go. So I'm talking about this now from the point of view of the care that is required to set up newborn screening programs. It must be embedded into existing public health program for the screening and follow-up. And the programs that are available in our countries are the immunization clinics, the maternal and child care, program, malaria control, the PEPFAR program for HIV, and these are very important established programs that we can integrate newborn screening into. And so we, for each program, before you set up, you have to define where the samples will be collected, when the samples will be collected, the screening laboratory, the test to be used for the screening and confirmation, what happens to the results, the persons responsible to follow up the patient and to schedule clinic visits, and where the confirmatory testing, when and where it will be conducted, and the clinical network for follow-up and care of screen-detected babies. So all of these have to be planned, and then of course the data, has to be carefully acquired and stored and then used for a program. So for the Federal Ministry of Health, there's a policy for newborn screening, and the protocol for newborn screening that was established, and the government has 6 newborn screening centers in these locations you can see on the map. But because they were based on high performance liquid chromatography, they didn't really go too far. And then this is a protocol for the Consortium on Newborn Screening in Africa by the American Society of Hematology, and that is being demonstrated in 7 African countries, as you can see on that map. But if you look at newborn screening in African countries, you will see that most of them are using isoelectric focusing. Isoelectric focusing in Nigeria, in Liberia, Burkina Faso, Kumasi is the oldest one, Republic of Benin, and Senegal, Dakar. This is by PearFab Foundation. And this paper that really looked at it and described the programs in each country was in 2020, but last year they also had an updated current status of newborn screening with DBS worldwide, a comprehensive review which you can look for and read. So anytime you see this kind of thing, it means there's a lot of interest in the topic. So many people are writing. So there's more than enough material. Each of them pilots newborn screening. So what we want to do is how can we go beyond pilots to have a national scale up of newborn screening programs? So I'm going to briefly describe 3 attempts to do this. One is the demonstration project by the American Society of Hematology Consortium for Newborn Screening, which was is a consortium within a collaboration between American Society of Hematology and African hematologists, like I said, in those countries. And it's just to demonstrate the effectiveness of newborn screening and early therapeutic interventions for babies with sickle cell disease in sub-Saharan Africa. Excuse me. So the consortium was able to negotiate lower equipment and reagent costs for newborn screening on the IEF platform. The other one is initiatives to enhance newborn screening using point of care tests. I think we kind of led this work based on when we did some evaluations of the two frontline point of care tests, which we published, and then a lot of countries have also done similar work following. But this was based on the SparkNet with the PIs. These are picture of when we did the hemotype SC, and we launched, the study was well publicized. So we tested across the 6 zones of the country the 2 point of care tests, sickle scan and hemotype SC. Then the third one is an initiative by the Sickle in Africa. So Sickle in Africa is a consortium that is in 6 African countries with a data coordinating center in South Africa. So we were looking at, we did this work, implementation science work within the Sparkle grant, where we had established a disease registry of over 34,000 patients in 6 countries. And so we wanted to find out how we can scale up newborn screening. And the method was exploratory, sequential, mixed method of assessment on the use of 3 technologies to facilitate newborn screening for sickle cell disease. In the preliminary phase, we evaluated the performance characteristics and cost of DBS point of care tests compared to standard POCT and isoelectric focusing and HPLC. Then in the quantitative phase, we screened 7,500 newborns across the 6 countries with DBS POCT. And DBS POCT, DBS is common to each of the standard methods, IEF and HPLC. And then in the qualitative phase, we conducted focus group discussions and in-depth interviews for all the stakeholders that are involved, the healthcare workers, the mothers, the policymakers. And the reason we did this was to assess the barriers and facilitators for DBS POCT newborn screening. And the screening was done within existing public health programs such as immunization clinics in primary healthcare centers to explore the ease of integration of newborn screening into these services, because we wanted to see how to scale it up. So the summary of what we are getting from these stakeholders is that the parents and caregivers want the sample to be collected in postnatal wards and immunization clinics, and they wanted more education for parents and outreach to communities with information to alleviate fears and misconceptions about newborn screening. While the policymakers felt that the significant barriers to implementation include parental reluctance, inadequate training for healthcare workers, financial constraints, particularly for families in hard-to-reach areas, with the recommendation that to overcome these barriers, we need to increase awareness, we need to increase the training for healthcare workers, we need to integrate screening into existing health services, and we need to ensure that there's government support for training and resource allocation. And so for the healthcare workers, the key benefits to newborn screening include early diagnosis leading to better health outcomes and improved life expectancy for affected children. And they felt that parents were more likely to accept point of care testing due to minimal blood requirements and quick results. And then they also felt that they should be given incentives. I don't know how that can happen, but people are used to aid So they want incentive for mothers to bring their babies for screening and for follow-up. Overall, everybody knew that collaboration with community leaders and existing health programs is essential to enhance the reach and effectiveness of newborn screening initiatives. So the challenges that we have found in this area is that the interventions are not readily available. There's lack of acceptance of results of screening, and there's loss of follow-up across the 7 countries of babies detected in newborn screening. And so there's a need to integrate into existing public health programs. And also, we are really looking at how to scale so that those in remote villages can have access. So follow-up is very essential in identifying. So after identifying the babies, we must ensure that they are followed up. Post-test counseling needs to be done. We have to enroll them into the prophylaxis for infection. We have to confirm the testing and genetic counseling, not only to families with the disease. HBCC is not really considered to be a disease, so they need to be told that. But those with the trait, we need to focus attention on those with the trait. So education and training, both for parents and healthcare workers, very, very important, and linkage to pediatric parent support group and other support groups. Enrollment of babies into centers who can provide comprehensive care, and primary health care centers may be more practical, as have been told to us by the mothers. So how do we deal? So some of the questions that we're still asking is the challenge of parents who are not willing to accept results when the babies look normal within the first 6 months. And how do we deal with babies who are lost to follow up? How do we have difficulty in tracking babies with no house address, and we are fashioning ways of doing this. So IEC materials are important, and this can be shared via social media, and we need to generate awareness. We are trying to do that by engaging the media. We are trying to create demand for newborn screening by patients, and we are trying to create awareness on the need to follow up. So we are giving these messages. Come, the screening is free, but you need to bring your baby for follow-up. So we are also trying to look further upstream in pregnancy. So what is the innovative approach? That is use of point of care technology. So we have tested this, we have implemented newborn screening using point of care technology. We have seen that it is feasible, and we feel that an approach with point of care in PHCs linked to clinical centers will be a good way of scaling up a newborn screening. And we feel that a multi-stakeholder engagement is required to achieve universal coverage, especially in high-burden countries. Looking at the private public health practitioners, also the public, looking at sickle cell disease NGOs, the ministries of education, the media, and the community. So what are the lessons that we have learned? There's a low uptake of enrollment following screening. I think the most that we have gotten across the countries is not up to 70% yet. There's a loss of follow-up, which is a major setback, and then denial of results by mothers because the babies look normal at first. And so we have to sensitize the population to accept screening and follow-up. We need to tell them that the babies will look normal at first, but they have the disease, and they need to be followed up for early intervention. So genetic counseling. So these are the people that we need to target: babies who are AS, babies who are AC, those who are SC, and SS. And we have this kind of cards that we give out. We write so it has genotype. You can see the genotype is is in quotes, because it's not really genotype, it's a phenotype. So we have the name, this is the information that we put. We say who has done the counseling, where is the health maintenance center, which tertiary hospital is this child linked to, which support group is this child linked to. Then we give the phone number, like a helpline. And then we want to synchronize the information that we are giving out by this simple flyer, that just explains what it is, how it is diagnosed, what happens after diagnosis, and what happens when parents refuse. So my take-home message is that sickle cell disease is a genetic blood disorder in high prevalence in sub-Saharan Africa, leading to early mortality. Newborn screening with evidence-based intervention saves lives of individuals with sickle cell disease, but countries have to make budgetary allocation, and multi-sectoral partnerships is necessary to achieve universal newborn screening in high-burden countries. A combination of standard methods such as IEF and HPLC in reference laboratories with point-of-care tests for remote areas may be required in order to implement universal newborn screening in African countries. Newborn screening should be followed by genetic counseling of parents with positive results. So keep an eye on the tray and the disease. And I wish to acknowledge the support of our university, the Federal Ministry of Health, the Teaching Hospital, American Society of Hematology, PECINELMA, who has been able to make sure that these 7 African countries have lower equipment costs and reagent supply, and then the Primary Healthcare Board, into which we are working, in 25 primary healthcare centers. We are doing the screening in Abuja. And then, of course, our funders, the Fogarty International Center that gave us this training grant to do this, and the staff, of us. So I want to thank you for listening, and we'll take the questions at the end. Thank you.
Thank you very much. I want to be sure that you can see my screen. Please, can I just have a confirmation that you can see the screen?
Yes, but we can see your screen.
Okay, thank you very much. Thank you, Mr. Moderator. The 2 speakers, Professor Nadu and Dr. Ahmed, have done fantastically. And I really, really, really want to appreciate them. They have made my job very simple. It's just that tonight we are looking at general genetic counseling, and tomorrow we'll be dovetailing into specifically sickle cell disease. But just to conscientize us as participants in this training, that genetic counseling is becoming extremely important, just like we have heard in the last presentation. And much, much more, than being important is the fact that almost all non-communicable diseases have genetic implication. And because genetics is affecting all non-communicable diseases in one way or the other, then it becomes very important for us to begin to look at this and look at it well. So tonight, we'll just be doing overview of genetic counseling. I have up to 9:50, but I will try very hard not to go that far so that we can spend some time for questions and answers. And so, as a way of introduction, there are so many conditions that are caused by mutations that move from parents to offspring. And I just try to provide a summary of some inherited genetic conditions. And in this slide, you will see that sickle cell disease tops the list. There are so many others there: cystic fibrosis, Huntington's disease, Tay-Sachs disease, fetal ketonuria, Marfan syndrome, hemophilia, and so on and so forth, and BRCA-related cancers. But what I want to draw your attention to is sickle cell disease. And tomorrow, we'll be spending a great deal of time looking at genetic counseling specifically for sickle cell disease. And we'll also be looking at different case scenarios, that we may face or encounter, and possible solutions to all of them. And like I said, one of them is sickle cell disease. It has been repeated almost in all presentations since 3 weeks ago through last week until this week that it is inherited in an autosomal recessive pattern. That means that both parents must carry a copy of the gene for the offspring to develop the disease. And that has been repeated over and over and over. Now, let me make reference to this person, Sheldon Clark-Reed, an American biologist and geneticist who formally introduced the concept of genetic counseling. Kudos to him, to Sheldon, for bringing this very great, wonderful concept to every one of us. What is genetic counseling? Simply put, it's a communication process that is concerned with human problems that have to do with either actual occurrence or risk of occurrence of a genetic disorder in a family. This definition is as old as 1975 by American Society of Genetics, but it is as relevant today as it was in 1975. So there are several definitions of genetic counseling that you come across actually are derivative of this American Society of Genetics definition of 1975. Take note of keywords: communication process, very, very important, dealing with human problems that have to do with either actual occurrence or risk of occurrence disorder. So when you're talking about genetic counseling, I'm sure in the course of the last 3 weeks, we have heard that it is not advising. So it's a two-way nature of interaction. And there's nothing that talks about advice when you're talking about genetic counseling. Traditionally, it's been defined as keyword non-directive, meaning that there is a counselor, a genetic counselor, who provides information so that the patient can be armed with information necessary to make decisions. So the decision that this individual is going to make is going to not just be a decision, but an informed decision, because he or she has been exposed to myriads of information that are going to open his or her eyes to be able to take the best decision so far for him in the particular situation that he or she has found himself. When we're talking about genetic counseling, we look at the goals, and the goals are many, out of which I just brought out a few here. One is empowerment of individuals and families. All of us are healthcare professionals. I believe so. Majority of us. I know we have epidemiologists, we have scientists, and so on and so forth. But all of us, in one way or the other, we are health professionals. And this is about collaborative arena where we want to make sure that who we are dealing with or relating with or interacting with at a particular point in time is an individual or it's a family or it's a community, we want to make sure that they're able to make informed decisions about their health and reproductive choices. And that can only be achieved when we have provided comprehensive information about the genetic conditions that are confronting these individuals, the risks that are therein, and the available options. So empowerment is a goal of genetic counseling here. The next goal, apart from genetic counseling, is that we want to help to review family and medical histories in an attempt to empower an individual or a family, because you are not a native doctor. And so you need to put your cues together, and to be able to put these cues together to formulate whatsoever it is you are going to base the decision that the patient is going to be able to form at the end of the day from. It includes reviewing the family and medical history. So family history, his story. History actually means his stories. So the family and the medical, his stories, they are essential in genetic counseling. And I know it is essential in all of us in what we do for our patients, whether you are clerking your patient as a physician or you are using the framework of nursing process as a nurse to interview or to interact with your patient, or as a social worker, or whatever algorithm you are using or standard of care. Gold standard of it is making sure that you are getting accurate and appropriate his story, history. Then being able to explain genetic inheritance patterns, and then assessing the risk factors and offering guidance for making informed choices about all that Dr. Eunice Ahmed has given to us and Professor Onodu just concluded a few minutes ago. So they are able to make informed choices about genetic testing, about disease management. There are some key aspects of genetic counseling which are essential. One of them is education and information. In the last presentation, we heard that, okay, some parents just deny and say no because the baby is looking well and looking okay. And that is where the issue of education comes in, public awareness, conscientization of people as much as possible. So genetic counselors explain genetic conditions, they explain inheritance patterns, they explain testing options, available management, and treatment strategies. All of these are important to be able to get to where we want the patients to be able to move to. Risk assessment is also very important, whether it is for individual, like I've said, or family risks, or even risk of developing or passing on a genetic condition based on his story that we have received from family or medical history that I just talked about, and followed by assessment, if applicable, the need for genetic testing, and then the disclosure of the results is also very important. Another key aspect of genetic counseling is support and counseling. It's not enough to take his story, whether nursing history, medical history, or family history, or whatever kind of history that we are going to obtain, but to provide emotional support, to address psychological, social concerns, and help these individuals and families to be able to adjust to the implications of a genetic diagnosis of risk. Tomorrow, we'll be looking at cases, and I believe every one of us will be able to contribute to how to actually help the patients to make an informed decision. So in supporting and counseling, there's need for the individuals to be able to make an informed decision. So we want to help individuals make informed choices about genetic testing, about treatment options that are available, about family planning options, and other kind of options that may be available. Another key aspect is collaboration with healthcare professionals. Let me say at this juncture that in our environment here, we do not have special professionals who are tagged genetic counselors. But in other parts of the world, you have genetic counselors for different kinds of conditions. You have genetic counselors who are with maybe master's degree, with undergraduates in basic biology and all of that, and you have them trained as genetic counselors. But in our environment, that is scarce. In fact, Professor Onodu will let you know in the efforts that has been put into making sure that we are able to get facilities where genetic counselors can be trained on the continent of Africa, and effort that have been put into that, and the difficulty that we have faced in reaching that. And so collaboration with healthcare professionals becomes very, very important. Genetic counselors work with other healthcare professionals like doctors, like nurses, to provide comprehensive care. And like I was saying earlier on, we can use what we have to get what we want. We can get people who are already established in their various professions. If they are interested and they are available and they are willing, they can be trained and then become genetic counselors. And it will be fantastic for such professionals who already have all or most of what is needed in genetic counseling as the fabric and the backbone of their own profession. Take, for example, history taking. His story that I said, whether it's a family history or medical history, almost all health professions have that. You have to obtain history from your patient before you are able to do anything. And you know this slogan that if you cannot assess any patient, you actually have no business caring for that patient. So it becomes very important. I'm going to jump this slide because Professor Onodu took some time to explain all of the kind of people who may need genetic counseling for us. So indications for genetic counseling, there are general indications for referral to genetic counseling in the preconception and prenatal setting. Like if there's an abnormal prenatal test result, like fetal protein as seen, or amniocentesis comes out and there's unexpected result, or there is inherited disease or birth defects that are noticed, or a mother has 2 or more miscarriages or even stillbirths, and if a mother is equal to or older than 35 years old. Now you will tell, this is quite debatable and controversial because there are so many people who are getting to this age and they are becoming mothers for the first time at this point. But I mean, we're looking at universality and an average situation that we are. We can discuss this after the presentation. And then, you know, in those days, mothers who have miscarriages or stillbirths, not even in those days, I've interacted with mothers who have various genetic disorders, and including sickle cell disease and others, that they do not even know, they are not even aware. And then it is what is calling attention, and the point of attraction is frequent miscarriages and continuous stillbirth experience. And then at that point is when people began to wonder, what's going on here? What really is this? And then investigations and all of that will prove to us that this is what is going on with these individuals. Now, generally speaking, genetic counselors are people who have certain attributes, and these attributes include the fact that you must be kind and compassionate. As a healthcare professional, it is embedded in fabric of every health profession to be a kind person, to be a compassionate person. But much, much more, you must be able to create the time that is needed and enjoy working with others. You must be somebody who has passion, you know, for helping people beyond the call of duty. And you must be a good listener. Listening is a very big business. It's a big deal and a big do. Listening is not passive, it is active. It inquires the entirety of your being to listen to another person in such a way that you can get and elicit all useful information that you need for that SCD. It is not as easy as you think. And if you are not a good listener, is an opportunity has come for one to begin to practice it. And always when I'm teaching on genetic counseling, I usually tell people that if you have young children, or if you don't have young children, you are a grandmother, you have grandchildren, you can learn how to be a good listener, you know, from them. If you tell them, come on, Doris, come and tell me what happened in your school today. And make sure you're not going to stop them. Make sure you allow them to talk from start to finish. Do not say, what is the equal to of this conversation? So what is the conclusion? No, you don't jump in and you don't assume anything. You just listen and you allow that child to finish all the stories that you want to tell you. If by the time you are starting this journey, your attention span is like 2 minutes and you have cut in, well, it's okay, you are not doing badly, then you can do it another time and begin to increase it to 5 minutes, to 10 minutes, to 15 minutes, depending on what exactly you are looking for, you're focusing on. But to be a genetic counselor, it is very, very important that you are not just a good communicator, but you are also an excellent listener. And you must be interested in the sciences, because you see all the explanation we've listened to in the course of this webinar from day one till now. I want to give kudos to all participants for doing excellently well in the first presentation, where you are all getting the correct answers as regard who has all those 4 different cases that were shown to us. Fantastic. But the truth is that for us to be able to understand that, the information behind it, the background information, one must be interested in the sciences. Let me quickly take us through algorithm to genetic counseling. Whatsoever we are dealing with, initial assessment is vital, where we gather information and provide information about sickle cell disease, if you're dealing with sickle cell disease now. And the pedigree construction is vital, plus risk estimation. Professor Isa Ezekiah took us through lots and lots of various methods of estimating risk, and we'll look at a few of them also tomorrow in the course of the presentation on genetic counseling tomorrow. Then risk communication and consideration for screening, which is very important, whether it's carrier or prenatal or newborn screening and diagnosis, like we just heard in the last presentation. Then disclosure of results and addressing concerns and available options. It's not enough to draw your pedigree, to estimate the risk and communicate it, and then you just leave it like that. No, the concerns have to be addressed, and then available options must be there, and then decision making on the part of the person who is concerned, or the individual or the family. And then, of course, linkage with specialists who are able to do justice to whatever it is, the decision that the individual has made, where referral and follow-up becomes very important. Essentials of genetic counseling, several of them, I've talked about gold standard of family history. And I've said medical history is important. So his story, vital. Whatsoever it is that we're doing, it is very important that history is given attention. And then pedigree construction, clinical examination, history findings, all those things that we were told in the last presentation last week and today that we've heard also from Dr. Eunice Ahmed's presentation. And then, of course, DNA studies results and confirmatory diagnosis, calculation of recurrence risk, and then counseling on available options, and then follow up as much as possible. I'm managing my time. I know I have like 8 minutes more, but let me just take 3 minutes and then I'll be off. So in conclusion, the use of genetics in clinical care has increased, raising both interest in and concern about the impact of genetic information on the life of individuals and families. Every one of us here tonight and who have been here in the last 3 weeks should begin to fall in love, honestly speaking, because the entirety of all of this is genetic counseling with special emphasis on sickle cell disease. Every individual we come across, we make a difference in their lives. And the tool we use in doing that is genetic counseling. So while we are interacting with our patients, the use of genetics is increasingly becoming topical. The interest that it is generating is not only among the patients, not only among the family members, but among healthcare professionals as well. So the scope of genetic counseling is expanding and is evolving. Likewise, among patients and professionals, and surprisingly, even among community stakeholders. So education becomes imperative. And that's one of the reasons why this webinar is on. And I really want to appreciate each and every one of us for our attention, for our participation. And I look forward to continue this conversation tomorrow when we deep dive into genetic counseling in sickle cell disease specifically. And then we'll look at all our roles. And we have another great presenter or facilitator from Ghana who will also be contributing to this discussion tomorrow. So I would like to stop here and then we can take all the questions. Over to you, Mr. Moderator. Thank you very much.
Thank you so much. Please, can we give a round of applause to Prof for this wonderful presentation? This was a very enlightening and a beautiful expository one. I want to appreciate all our presenters, Dr. Ahmed, Professor Nodu, and Professor Adejumo. Thank you so much for today's wonderful session. It was very enlightening and very expository. Thank you so much, ma'am. Right now, we'll be going to the question and answer session. And we'll be starting with the first speaker. I don't know if Dr. Ahmed is still with us.
Yes, I'm on.
Oh, thank you so much, ma'am. So we have a couple of questions for you, which I am trying to, I'll be reading it right away. Oh, yes. So someone was asking, Esther Ampong asked, how long should an individual wait after transfusion to do an electrophoresis?
All right. So thank you for that question. So typically we advise at least 3 months after a blood transfusion before you retest with the HB electrophoresis to determine one's actual phenotype. Yeah. Thank you.
Okay. Yeah, thank you, ma'am. So we have another question from Richard Osai. He asked, knowing the flaw of electrophoresis in the newborn, what are the prospects of other diagnostic techniques such as dermatographics in newborn screening?
That's an interesting question. So that has no role in newborn screening. We cannot use the what's the word? Yes. So that's basically about reading the palms of an individual to determine some genetic conditions or some abnormal conditions. But in sickle cell disease, the only way to know is by screening or by testing. Okay, so that has no role. Thank you, and over.
Oh, thank you so much, Ma. Another question here for you, Gustos, from Olumide Adeleke. asking, can we regard both AS and SC as carrier states of hemoglobinopathy?
Sorry, can you take the question again, please?
Yeah, the question goes thus: can we regard both AS and SC as carrier states of hemoglobinopathy?
Yes. So AS is a carrier state or a sickle cell trait, meaning they just carry one abnormal hemoglobin, that's the S. Similarly, AC is also a trait for C. So they only carry an abnormal. So they have one normal, which is the A, and then abnormal is C. So they are carrier states for hemoglobinopathies, okay? So hemoglobinopathies are basically abnormal forms of hemoglobin. So not only the S is considered a hemoglobinopathy, but the C is also considered. So they are carrier states for hemoglobinopathies, yes. Thank you. Over.
Thank you so much, Doc. So another question here for you goes to us from Benjamin Adejumo. Since various hemoglobin variants can be found on the same band, how do we differentiate variants on the same band on the electrophoresis?
Okay, so as I said, some bands migrate together on the HB electrophoresis, but there are other testing methods that can differentiate those bands. So I think I mentioned the citrate agar electrophoresis, which is able to differentiate, for instance, S and D or S and G, which would otherwise migrate in parallel for HB electrophoresis, but the citric agar can separate it, okay? You can use other testing methods like the HPLC, IEF also to help to differentiate the various bands. So that's why I said HB electrophoresis is usually, it can identify the common variants of hemoglobin, but sometimes when there are additional less common forms, you may need some other complementary test like the citrate agar electrophoresis or an HPLC, etc. Thank you, over.
Thank you so much, Doc. Another question here for you, Gustos. If a known SCD patient has malaria and his PCV is 20, should he be transfused with blood ma?
If there's a clinical indication for the transfusion, yes. But I don't think the indication for transfusion has to do with a number, okay? So in sickle cell, we know they typically would have a lower than normal hemoglobin expected for age and sex, okay? But we need to know what their steady state or what their baseline hemoglobin is. So that's when the patient is healthy and then this is now their new normal hemoglobin that they normally will function under. Okay, so if the person has malaria and then their HB has significantly dropped from what their baseline was, yes, then you may want to consider a transfusion. But again, you also have to tie it in with the clinical picture. Is the patient showing signs of decompensation? Is the patient having symptoms of anemia? Are they feeling dizzy, weak, and all that? So you need a number of things to consider before you make the decision to transfuse an individual, okay? So we don't only use the numbers, that's the HB numbers. Okay, thank you, over.
Yeah, thank you so much, Doc. Another question here for you, Gustos. The citrate agar electrophoresis and cellulose acetate, please, which one is more accurate? Thank you.
Okay, so I wouldn't call one more accurate than the other. As I said, they are more complementary. So what the other one has limitations with, maybe the other may be able to make up for it. Okay, so we do not necessarily put one higher than the other. Okay, because the advantages, that's why I brought out the advantages and disadvantages. Okay, so for instance, the HB electrophoresis is cost effective. So maybe that is what might work in a certain context. So we cannot say that HPLC, because it also quantifies, is more superior. Maybe in that same context, they may not have the skill to perform it. They may not have the expertise to also interpret it. And maybe the cost also the cost implications too might be another thing to deal with. Okay, so HB electrophoresis is effective in diagnosing the common hemoglobin variants. Okay, so if it fits a certain context, it might be good. Where there are limitations, you may have to make it up with another type of test. So these tests are basically, I would say, complementary rather than one superior over the other. Thank you. Over.
Thank you so much, Ma. And we have last two questions for you before we move to Professor Nodu Obiageli. What are the clinical implications of HbAc getting married to another HbAc, which can lead to an offspring of HbCc? Doctor, are you with us?
Is this my question still?
Yes, ma'am. So
Okay,
your question.
right. Sorry, I thought I heard it was directed to
Yeah,
Prof.
I was saying that last two questions. So after this, one more for you, ma'am.
Okay, all right. So when you have two hemoglobin C traits, there's a chance that they can have an offspring with hemoglobin CC. Hemoglobin CC is not sickle cell disease, but it's also another type of hemoglobinopathy, which I said is a hemoglobin disorder. It tends to give some mild type of hemolytic anemia. Okay, so generally they are not very sick, but they may have some mild hemolytic anemia. Yeah.
Okay, thank you, ma'am. So the last question for you from Olumide Gustos. Are PCOCTS, e.g. sickle scan, used as screening or diagnostics tool in newborn screening?
Is this my question also?
Sorry, this is not yours. This is for
Okay.
Professor
Right.
Obiageli. Thank you so
Thank you
much,
very
Doc. Yeah, thank you so much. Is Professor Inodu with us?
I am. Yes. What was the
Thank you.
question?
Oh, thank you so much, ma'am. Olumide Adeleke asked, are the PCOCTS, e.g. sickle scan, used as screening or diagnostic tools in newborn screening?
They are used as screening.
Oh, okay. Thank you. So another question for you from Oladapo Deborah Gustos. Please, ma, do AS also have crisis growing up with a sister who was a? Please, ma, do AS also have crisis growing up? I don't understand this question.
No. Actually, no. Usually not, because the level of S is quite small, is low. It's really not beyond 35 to maybe 40%. It's not enough to cause sickling. So typically they don't have a crisis, except if it's something else other than AS. Maybe some thalassemia involved there. So the person may have a very high concentration of S.
Oh, okay, ma. Thank you, ma'am. Another question for you, ma'am, from Josephine Abiolu Gustos. In the case that the parent receives screening of a newborn baby post-counseling, what can we do?
In the case that the parents resist screening?
Yes, post-counseling, for a newborn post-counseling.
Oh, yeah, you can't force anyone. You cannot force. There's no legislation in the country now that makes screening mandatory. So, but I believe that we always have to explain, what the risks are, what the advantages are for screening, and then just, talk to them and see if they will. Sometimes, maybe when they hear from another person, who has a child with sickle cell disease, it might make them to change their mind. But the best we have to do is to offer the services and give the counseling.
Okay, thank you so much, ma. Another question from Charity Osegalis Costos. Is newborn screening taking place in primary healthcare centers in Nigeria now?
Now, I know that in two states, FCT in 25 primary healthcare centers, also in Kaduna State, not all the primary healthcare centers, but some primary healthcare centers and some tertiary. The Southwest zone, Southwest Nigeria, has also started a newborn screening program. And we used to have in Katsina State, we have in Anambra State, we have in Delta State, we have pockets of newborn screening. I didn't put the table for Nigeria because this is supposed to be a two-country, presentation. So, but there are pockets of newborn screening going on. Remember, I told you about the MDG sickle cell centers in Kefi, in Yenogwa, in Ebutemeta, in Benin Kebi, in Abakiliki. You have those newborn screening centers. So there are pockets of them across the country.
Oh, okay, ma. Okay, ma. Thank you. Someone also asked another question. Is there a method of testing for an unborn child? If yes, at which trimester or at what month within the pregnancy is this test carried out to determine the sickling status of the unborn child?
Usually within the first trimester, because so it depends on what the intention is. If the intention is to abort the baby, then it has to be done early enough not to be a risk to the mother. If the intention is just to get the information, so there are different stages in pregnancy that you can access depending on the kind of technology that you're using.
Okay, thank you so much for that brilliant answer, ma. Another question from Amina Jafar goes to us. Please, where do you think is most visible place for collecting samples from majority of newborns for screening?
If you remember, I did say it's a heel stick. I did say that is a heel stick. And if you see where I put the babies, I don't know if I can still share my screen.
You can. I've stopped sharing.
Okay, so let me see. Yeah, so it's a heel stick essentially that you have. That's the heel stick, right? And then if you see this, you see I put this, so it's the heel, a V, yeah. It's a heel stick.
Oh, okay. So Charles also asked another question. Thank you for the brilliant answer, ma. Charles asked another question. Please help me to understand the meaning. I don't understand this English. Please help me to understand the meaning this 1 year, 3 months hemoglobin electrophoresis outcome. HbA equals 28.2, high HbC. I'm not sure if you would understand this question if I read it out.
Yeah, just go on.
Oh, okay. HbA equals 28.2 L, HbC equals 3.8 H, HbS equals 32.1 H, and HbF equals 5.9 H. Please, what is the hemoglobin type for these results?
It looks like the person may have had a blood transfusion, because you're having how many types of hemoglobin in that person? I think I had an S, and I had an A, and I had an F. So somebody may be SC and receive blood transfusion.
The person said, what is the hemoglobin genotype for these results?
If there was a blood transfusion, that could be someone who had. So they have to define the clinical situation, because normally you don't expect to have someone to have S and C and A, not A to A. You understand? So they should say what happened, what was the clinical history in that patient? Did the patient have a blood transfusion?
The person who asked the question is not able to respond to this question, ma'am.
Okay.
Thank you so much. That was the last question for you, ma'am. Thank you so much. We're moving to Professor Prisca Adejumo now. One of the questions for you here from Olale Christiana goes to us. How can we counsel couples who are medical personnel and still want to go ahead in marriage despite the fact that they are carriers?
Is their choice. Tomorrow, we will be dealing with several cases. And I think that's one of the cases we'll be looking at. But generally, yes, generally speaking, one, on a surface level, they are medical practitioners. They have insights, they have understanding. But when you are counseling, you do not say because these individuals should know, because your role at that point as a genetic counseling is to provide information that will help them to make an informed decision. So it is number one, their choice, that's what they want, but your role is to provide all the information that is at your disposal. And when you have provided all that information, the decision is still theirs once it is genetic counseling, which is different from other counseling. In genetic counseling, I said it is not directive. So the individuals are going to be assisted to make an informed decision at the end of the day. But tomorrow, we'll be dealing a lot with cases why with somebody who is AS, why will if he says, I'm in love and I'm not going to stop, this is the person I want to go ahead and get married to, and that person is SS or that person is AS, what do we do? And what is your role as a counselor? Tomorrow we'll be looking at all of that. So let me just pin it at that place. Thank you.
Oh, thank you so much, Prof, for that beautiful response, ma'am. So this other person that is asking, please, my question is, should every sickle cell individual be taking hydroxyurea or for only those who experience clinical symptoms of SCD?
Should every patient with sickle cell disease take hydroxyurea? I think Dr. Isa Esikaya told us about that. Maybe Professor Dr. Ahmed and Professor Osei can contribute to that question. We were told the complications, the side effects of hydroxyurea and the role it plays, and why everybody and everyone should not just go ahead and say, because this is what it does, I'm going to go ahead and start pumping myself with hydroxyurea, considering all the side effects and all the drug-drug interactions and all the things that accompany it. Who is the best person to take hydroxyurea? How do you take hydroxyurea?
Prisca,
Obi, please,
Prisca, please. We really don't want to discourage people. It's a very good disease-modifying treatment that has been tried extensively in sub-Saharan Africa. It's been tried extensively in several clinical trials in Nigeria. It has been shown to reduce the rate of vaso-occlusive crisis, to prevent stroke in children, especially in an environment where you have you don't have transfusion support for those who are at risk of stroke. So actually, the level of information now is such that it is considered not good practice if you don't offer patients hydroxyurea from the age of 9 months. The NIH in 2014, that's more than 10 years ago, gave the recommendation that we should put babies on hydroxyurea from 9 months of age. So it's a very, very, very simple drug to use. It's oral and it does so much good that the people who take it, know that they don't really have so much problem. But of course, every drug has a side effect, but the side effects are much less than the benefits of taking it. So I wouldn't discourage people from taking hydroxyurea, but they should just be monitored, or even low dose, hydroxyurea can still confer some benefit.
Okay,
So,
thank you.
yes.
Thank you very much. In the
Yes.
community settings where we are, you see patients know that, okay, adoxuria is good, and without any prescription, without going to any hospital, they just begin to move according to the prescription that somebody has said, oh, the drug of choice now, which is very good for us, is adoxuria. And that is where I was coming from, that yes, it is good, but do not by yourself go ahead and say that because somebody said adoxuria is good, you just go and start pumping yourself. In the first presentation we had a lot of explanation of how good it is, and of course the side effects that accompany it, and so many things were generated. I agree with you. Nobody is discouraging anyone from taking it, but please do not go ahead and take adoxuria because somebody else is taking adoxuria. The question that person is asking is it all patients, whether you need this or you don't need it, everyone should just be taking adoxuria? Yes, but it must be prescribed or by a doctor or a physician who has seen that patient, or hematologist, or somebody who is taking care of a patient with sickle cell disease. Thank you.
Yeah,
Over
you're
to you,
right. Yeah, because we shouldn't wait for them to get complications before we start. You can see, I don't know if you can see my screen. You
I
can
see.
see. So, yes. So this is it. This is the NIH recommendation.
Okay.
And yeah.
Thank you.
Yeah, thank you so much for that beautiful and brilliant responses. I also want to contribute to that question. So one of the things I also want to contribute is that clinical trials outcomes dissemination are a bit kind of poor, especially to the public, for them to actually have, to have a lot of knowledge about it. And what Professor Adejumo was saying is what has battered issues that brothers around AMR today. Or because Flagy has worked for stomach pain, any form of stomach pain, in majority of the household, everybody goes for Flagy, which most times what is causing the the stomach pain might not be Flagy oriented. So it's very important that before anybody goes for any medication, they are probably recommended by a physician to understand the baseline, the conditions that are possibly comorbid or the status of the individual. So the next question for you, Professor Adejumo, is: can the blood of a SCD be drained and be replaced with LD hemoglobin?
And
the blood of a sickle cell disease patient be drained and be replaced with LD hemoglobin?
The way the question is asked, drained. Talking about
so almost something like dialysis. No. So I'm not sure this person understands.
Go ahead.
So I just want to say, I'm not sure this person understands erythropoiesis, or what do you call this, blood production within the bone marrow. This person is saying that, can we remove the blood from somebody that is not LG and now pump LD blood into the person? That's the question.
It's actually what they call a red cell exchange blood transfusion.
Thank you.
And it can be done in the acute situation where you're trying to prevent a stroke or acute chest syndrome, or the person has priapism, So in the acute situation, but that the sickle red cells will still come back, right? Because the person is actively making those cells. So sometimes we have a chronic blood transfusion program in which every 3 months they are exchanging, but they don't really remove all of the sickle cells. They just tend to get it below 30% of the total. You understand? So you can't drain all the sickle cells.
Okay, thank you very much. I was thinking that way. Maybe the person is talking about autologous blood transfusion, which is the same thing as what you have said, autotransfusion. But to say you drain is like you intentionally drain the blood of the person. So in autotransfusion, you collect a patient's own blood and infuse it. So it's just the way the person puts the question about you draining the patient's blood. That was what put me off a little bit. But it's okay.
Yeah.
Thank you very much.
Yeah, it's just that with auto, it's for sickle now, you won't collect sickle cells and give back sickle cells.
To the patient,
So
yes.
we exchange it. It's exchange blood
Okay.
transfusion. Yeah.
Yes, thank you. Okay. Any other question?
Yes, Prof. Another question we have here is, please, can any medication alter the result of the test options? Okay, this is for Dr. Ahmed. The person said to Dr. Ahmed, can any medication alter the result of any of these test options?
Is she still?
Yes. Hello.
Yes. Hello. Yeah.
Yes. I would think that maybe hydroxyurea, because it would increase one's hemoglobin F. So it may increase your level of hemoglobin F, but it will not change your phenotype. So if you are SS, your hemoglobin electrophoresis will still show SS, but maybe your proportion of F may have increased. And that's how a particular medication can alter. But it doesn't change what you would otherwise be. Okay, so it only influences the hemoglobin F, but not the other fractions like S or C or even your A. Okay.
Oh, okay. Thank you, ma. Someone else asked, Professor Adejumo, is there anything like hemoglobin fraction?
Sometimes you sit in a lecture and they said it, Dr. Eunice showed the fractions, and then somebody is asking the same question.
Maybe the person has gone out. Hemoglobin A, hemoglobin A2, hemoglobin F, hemoglobin, all those that were shown. Dr. Eunice, do you want to just say one word concerning it? Because it was in your presentation, actually.
Okay. So yes, hemoglobin fraction is just a portion of or proportion of your hemoglobin in one form. So for instance, if someone has AS, so you're talking about hemoglobin fraction of the S, it's the component of the S out of the total amount of hemoglobin the person would have. I don't know if I understand.
Eunice, you can just show your slide. You can just show your slide where you talk, because you have it on your slide.
Yes, please. Okay. Okay, so I'll reshare mine.
Okay, while she's sharing, I'm checking through the questions, and I saw somebody saying, Evans Kuma. They say, how different is genetic counseling from normal counseling? So are you there, Dr. Eunice?
Yes, I'm here. I'm just trying to share my screen.
We have 5 minutes more. Wow.
Okay. Can you see my screen, please?
Yes, but it's showing references.
Yes. Okay. I'm sorry. Yes. So I believe this is a slide. So I showed hemoglobin fractions for a normal adult and then in a child. So normal adult, you expect hemoglobin A to be about 90 to 98%, and then A2 no more than 3%, and F usually it's quoted 1% mostly in most books. Yeah, so these are the hemoglobin fractions. So a portion of your hemoglobin as a total of everything that you have. So I hope this is clear.
Okay, thank you. I hope the person gets what she's looking for. So for the person who is, I'm just looking directly on genetic counseling questions to help the moderator. The person is asking about how different is genetic counseling from normal counseling, Evans Kuma. Like you have said, it's genetic. So genetic counseling focuses more on genetics. This is more with inherited. Dr. Ahmed, Eunice, could you please mute your microphone? Thank you. So genetic counseling focuses more on inherited conditions, genetic testing, risk assessment, all those issues that we've addressed here. So they address genetic conditions. While general counseling, primarily, we talked about one word, which I want you to take note for genetic counseling, is non-directive. And it means that it was on the slide that I showed that the counselor helps the individual or family understand the genetic risks and make informed decision. But the decision is not of the counselor. The counselor is not to tell the client or the patient or the family or whoever what to do. But in general counseling, there can be more involvement of that. There can be more involvement of direct guidance, therapeutic interventions, things that you need to do to address, depending on the prevailing circumstances that the patient has found himself or herself, things that can help to address some emotional or behavioral issues or problems or challenges directly can be handled. But genetic counseling, no, it has to focus on providing things that are related to genetics, and it is primarily non-directive. I hope I answered that question. I also saw another question. I don't know whether moderator has passed it. It says, I've left it, but it's saying that what is the role of the role of social workers in genetic counseling? And somebody else, which I will ask, I would like Professor Nodu to answer. The person said, is there any opportunity for psychologists in this training to have genetic counseling? For that social worker, I think what the person is trying to ask is, what is the role? Why are social workers involved in this training? That's my understanding. And I'm going to address it from that angle. Anybody can also contribute to it. To my understanding, social workers are very important in genetic counseling. They play a vital role. They can help individuals, they can help families cope with the psychosocial aspects of genetic conditions. They can help with emotional aspects of genetic conditions. They can assist with family planning decisions because there are people who have access. They can go to patients' home, apart from domiciliary nursing, which is fast, fading out. Social workers have opportunity to really visit patients' home. They have opportunity to interact with patients so they can interpret complex conditions vis-a-vis peculiarities of the patient's environment, patient's surroundings, patient's home situations, patient's familiar peculiarities, and so on and so forth. And they can also help with communication between the patient and the family members. They go a long way to break things into simpler terms and address potential conflicts that those nurses and doctors and everybody in the hospitals may not see. They may not be able to see those things. So they are very helpful when it comes to providing relevant support services. So if you are thinking as a social worker, you are in this meeting, or you are in this program, and you are thinking, what is my role here? There are 1,001 roles that you can fit in perfectly into genetic counseling as a social worker. For the person who asked about a psychologist, I don't know where the question is now, but I saw it, and it's asking whether they can be given opportunity to gain admission into any accredited university to pursue genetic counseling with emphasis on sickle cell diseases. I have my reason why I want Obi to respond to that question, and then I can add something to it as well. Obi, do you want to say something about giving opportunity to people, psychologists specifically? Aaron Opiat Obeng is a questioner.
Yes,
Pardon me.
absolutely. Yes, psychologists, by way of training, counselors, that's what they use. They use counseling as therapy. So they will be actually ideal, for this sort of thing. I know in my center, we got a clinical psychologist. I think maybe this is the second year he's working with us. And he was one of the first people that we sent for the genetic counseling program. So they are quite suited, for that. Prisca, was there something else?
No, I thank you, Obi. What I remember quickly, how difficult it was to get people when the advertisement went out to get people who are interested in applying. So to see somebody asking that if it's possible to get this kind of a thing, that's why I just said you should respond to it.
Yeah. But I mean, we are not going to get random people. We want people who will be within our institutions because of how we want to build institutional capacity for training, having training programs, established training programs within the institutions.
Yes, thank you. This person is in Ghana, is an institution in Ghana, accredited in Ghana, and is interested in pursuing genetic counseling with emphasis on sickle cell disease. So thank you very much.
Yeah. So in Ghana, we have the West African Medical Genetics Center in University of Ghana. They have a 2-year program in genetic counseling there in Ghana, in Accra, University of Ghana. So he should go there. It's a well-established program.
Okay, so thank you very much, Mr. Aaron Apia Obeng. I hope you are the answer. We can take the conversation on our side of this. I'm sorry, it is 2 minutes past 10, and we do not want to take us beyond the stipulated 2 hours. Pardon me for tonight. And I think we are done. What we are just going to be doing is Honorable Fawale giving the vote of thanks and then appreciating everybody. And I will say tomorrow morning, please, it is very important to be here early so that we can start the class on time, the session on time. It's 6 a.m. for Ghanaians and 7 a.m. for Nigerians. That's all I will say for tonight. The rest, very important information, will be coming up to us tomorrow after the presentation. Over to you, Honorable Fawale, for photon tax.
Yeah, thank you so much, Prof. It's been a very beautiful and brilliant, insightful session this evening. I want to appreciate our resource persons and our faculties, Professor Adejumo, Professor Obiagile, and Dr. Ahmed. Thank you so much for your time. And to all participants who has been part of this, training for the past 3 weeks, we appreciate you. And like Prof said, let us keep up the energy to, be punctual tomorrow so that we're able to meet up the class, and we are not going to be missing any important session. Thank you so much, and see you all tomorrow. And well done to all the local organizing committee members as well who has made this possible, who are working behind the closed doors. Thank you so much. Have a restful night, everyone.
So 1 second. Evans has put the address, the link to that center in the chat. So that's the person who asks a question can pick the link to the West African Genetics Center. It's a master's program, so they can pick it from the chat, please.
Okay, thank you very much. Just check it on the chat. Thank you.
Thank you. Good night, everyone.
Good night, everybody. Please, LOC, let's meet very quickly. Thank you, everyone. Good night. Have a restful night. Sleep early and wake up early tomorrow morning to be here. Thank you.
Hello.
Hello, Mr. Shola. Somebody is saying hello, Mr. Aaron.
Yes. So this is Aaron. I have seen that people are putting questions on a chat box asking whether we are not taking attendance today. But the attendance poll has been launched long ago.
It was launched long ago. Please, I think it's still there. If you go to...
Yes.
I don't know why they are not looking at that. Anyway, don't worry yourself. I think we will get it from Zoom. Because you can't go, many of them,
maybe it can be placed on the platform for them to know how to navigate it. They kept asking that question. I don't know how.
That means many of them are assigned.
Yes. From what I saw, I think.
Mr. Shola, are you still there?
It's only 238 that took the attendance.
No, I was watching up to 300 and something. Okay. Some of Kamaruddin said no attendance tonight. Mr. Kamaruddin, there was attendance. It was launched here. I think, Mr. Shola, are you in? Let's close this meeting and then go to LOC platform to discuss.
Yes, you are the one that can close the meeting. You are the host now.
Okay.